Well, I want to talk about an experience that I had where this technology could have helped a lot. 2 months ago, this patient, a 70-year-old patient, she already had diagnosis of endometrial cancer that was being treated, and she was on vacation from chemotherapy. And during the monitoring process, a renal cancer was found. She had a tumor. She had a specific issue here. She was a Jehovah's Witness, and they refused to get blood transfusions, so that really makes it complicated to manage these patients, and the institution always respects these patients. Therefore, this patient presenting with kidney tumor 5 centimeters. Can I see my next slide, please? As you can see, a large tumor, inferior pole, vascularized, and given that she refused to receive blood transfusion and wouldn't sign the consent, she was sent to referred to an interventionist. We discussed the case. Next, please. Guidance would be for embolization combined with microwave. So embolization was indicated because we wanted to reduce the risk of bleeding as much as we can. Ablative therapies would bleed a little, but we didn't want to run any risks in these cases, so we indicated ablation. So here, a vascularized lesion, and here on the right, after embolization. This was performed. The patient was admitted to the hospital, received embolization, and the next day she was referred to ablation. Next. Here you can see post-embolization, the nodule hyper-attenuating, discretely hyper-attenuating. And you can see that the CT scan gives us the precision to see everything that's around it. So when you're going to do ablation, what does that mean? I'm going to put a needle in the tumor. This is a microwave needle that will go up to 80 degrees, and it will destroy according to temperature. But you can see it's near the spleen, the colon, and many other structures that cannot be injured. And as we saw from our French colleague, you have to be very careful with that. And tomography is the ideal method for these ablative therapies and enables us to place the microwave antenna and perform a procedure which is a hydrodissection, where we protect these structures from heat. The CT scan enables us to have high precision in positioning and repositioning the needle. Next. So a number of different positionings were made, third, fourth, and different positions in the tumor, and we monitor how the tumor is shrinking. Here we have 5 cycles. Each one lasted 5 minutes at this power, at a total of 1 hour of procedure. And this is the final result. No bleeding, full destruction of the tumor, and therapy success. So by combining these two methods, if we had this technology available, this could have been done in just one procedure. So that impacts not only for how hospital stay, financial impact, and I believe that that adds value to the system and to the patient. So this is an example of the impact that this new technology can offer to our Brazilian patients, starting off in Recife. Thank you, Marco. That's an excellent example, very optimistic for all of us, especially for oncology treatments. As Dr. Menezes mentioned, with that technology, a patient wouldn't have to undergo 2 procedures, less stress, less money spent on anesthesiologists and procedure, among other things. So, Dr. Nasser, you do a lot of embolization. How do you see this combination of these techniques? Now, it's a reality. Liver lesions, we're always combining embolization or chemoembolization associated to ablation. Marcos's example is sensational. You can see a hydrodissection. We've been seeing how they can access posteriorly or anteriorly and reach the lesions. So that's a huge advance to all of us. And the possibility of vascular catheterism so that the lesion can be treated with and aiming at potentializing the result or increasing that potential and also the result. And in intra-op, as you mentioned, with this type of equipment, we can have more safety in the case of you mentioned about bleeding. I do believe in advancing with safety. That's the two things about this equipment, in my opinion. We're going to exceed the limits that we have today. So if I have a very complex case, so high risk of bleeding, I can take the risk in doing the procedure or trying if I know that I have a catheter that's not going to cause bleeding. That enables me in advance in referring patients to procedures that we currently do not do today. Plus streamlining the rooms. Talking to some colleagues that already have this technology in some centers where all the rooms are like this, you no longer split the rooms up. You go in with the patient to do everything the patient needs. If you use a CT, fine. If it's an angiographer, fine. If you need both, you can use both. So that's as we've been seeing. In the beginning, technology is a bit more expensive, less available. But I believe that this will be the format, the future of an interventional room, right? Which is the present now. I believe that's what we're going to see in interventional radiology from now on. To add on to what Marcos mentioned, Dr. Garnon talked about the fusion of the image of fluoroscopy with the CT. And for those that work with the aorta, right? When we fuse them together, it's never so clear in the CT. In fluoroscopy, we see some organ images, but in his images, he showed that with this CT, the image is so clear. So I believe that for that type of procedure, is that it's as if you were navigating in a CT, right? It's going to be much better. Exactly, Nasser. That's one of the advantages. Cone beam CT has a limit, right? When you have a whole big volume, you can't see the outside. So, but in this case, you have better fusion. You can have 3D roadmaps, so you can see the fenestrations, branches, endoleaks, and you inject less contrast. So it's intra-artery and it's diluted. That's another important aspect of renal protection. And you can immediately treat endoleak by puncture. So today we have a limitation in ablation techniques, which is the size of the tumor. So in general, limited to 5 centimeters to be ablated. When we combine these techniques, do you think we can advance in that? I'd like to hear Marcos's opinion as well. I believe so, because we already have scientific evidence that these endovascular techniques work. And the ablative techniques also work. They're already used, as was shown, when you can do prior embolization to decrease vascularization, heat, and combine therapies with better results. So without a doubt, even though these technologies are expensive, they're here to stay because we want to evolve and have more safety and efficacy for our patients, without a doubt. And to close your participation here, we have another question for Dr. Marcos Menezes from Mateus Correa. He's asking, as the current president of SOBRICE, what does 4D CT represent for the future of interventional radiology in Brazil? Well, I think that's exactly it. I see that this technology is going to be the standard in an interventional radiology room. All the technology, when it comes in, I know it's expensive, it's difficult to access. I know there's some limitations, but in my opinion, this is the perfect design for a room. Many hospitals in the world already have this. So memorials in New York, that's what is an interventional room. And I believe that that's what it has to offer for us. That's what an interventional radiology room is going to look like in the future. Today, we do have limits, as Philippe mentioned, about access and of our country, cost, and so on. But I believe that this is what an interventional radiology room will look like. We're adding more and more technology every day. We add more complexity to our specialty, and for that, we need the technology. So I believe that that is going to be the interventional radiology of the future, and that's a given, and that's a gift. Dr. Menezes, Rodrigo Frota is asking if you believe if one of the advantages is to facilitate passing a double J cath anterograde US guided? Yes, monitoring a double J is easier through fluoroscopy, as well as cementoplasty, where you have to inject and there's real time. So I think it's going to be much more interesting to do a lot of bone procedures through fluoroscopy. There are a number of procedures where this combination is an advantage. And I believe that we're just in the beginning of finding these new paths. I think it's a technology that's opening up opportunities for looking for new paths, so new combinations, new solutions, I'd say. I'm very happy to see a possibility of something new, and that's exactly what we see here today. This is a very interesting debate, right, Karina? But I think we're running out of time. So I'd really like to thank you all from the bottom of my heart. This exceeded my expectations. It's a technology that's here, that's coming. We have high expectations. And I believe that we're going to create an elite team so that we can promote this even more, reap the benefits, and even create concepts, right, Philippe? I think we can study new things, such as have an immediate CT after an aorta procedure to see if there's an endoleak. So there's that future that we're going to have to explore. And as Marcos mentioned, that's the spirit of interventional radiology. That's how it was born back in '64 with Charles Doda, and we're just following that line. Thank you very much once again. I know you are all very busy, and it's late tonight. Thank you very much. I hope to see you soon again.